Good morning, everyone. Welcome to GDC. How you all are doing? After a long time, I'm back with my another video lecture on medicinal chemistry, and the topic for today is the hypertension and the hypertensive agents. So, without wasting any time, let's start with the topic. Now, what is hypertension? Now, hypertension can also be called as the elevated blood pressure. So, what happens in hypertension? Basically, the blood pressure increases, or the pressure of the blood inside the vessels. It start pushing the artery walls, and due to that, a lot of pressure the artery walls faces, and due to that pressure the artery walls get damaged. Now that condition is known as hypertension, and due to that elevated pressure to the artery vessels, there is basically increase in the workload of the heart and the blood vessels. Okay, and that leads to the damage over the time. Now, as we are saying that hypertension in the increased BP situation. So, what is this BP, or what is this blood pressure? So, blood pressure is basically the cardiac output into the peripheral resistance. Now, cardiac output is basically the amount of blood that the heart can pump over a minute. Okay, so over a minute, the amount of blood that the heart is pumping, that is the cardiac output, and peripheral resistance is the resistance that the blood faces during the flow through the blood vessel, that is the peripheral resistance. Now, whenever there is an increase in the cardiac output or the peripheral resistance, then it can lead to the increase in the blood pressure. Okay, so these are directly proportional to the blood pressure. Then if we look on to this diagram here, now this shows the condition of the hypertension. So this here is the normal artery. It has a normal interior diameter. The blood can easily flow through that. So this is the healthy condition. So when this artery wall, okay, its thickness get increases, and there is the narrowing in the interior diameter here. The interior diameter get narrower as compared to the normal artery. So that condition is known as the hypertensive condition. Like this is the normal condition, this here is the pre-hypertensive condition, and this here is the hypertensive condition. So this diagram shows the condition of the hypertension. Now the classification of hypertension, basically the normal pressure or the normal blood pressure is 120 by 80 mm Hg. So whenever the blood pressure increases more than this particular range, for the systolic it's 120 and for diastolic it's 80. So that condition is known as the hypertensive condition. So when it reaches at 30 to 139 the systolic pressure and 80 to 89 the diastolic pressure, that condition is called the hypertensive stage 1. Then if it is more than 140 or equal to 140 and the diastolic is more than 90 or equal to 90, that condition is the second stage hypertensive condition. It is the dangerous state. Then the hypertensive crisis, the most dangerous state, where the systolic pressure is more than 180 and diastolic is more than 120. Now this condition needs the instant medical care, otherwise it can be a life threatening condition. Now this hypertension is the asystematic disease. Okay, so asystematic condition, so it needs it can be very dangerous at times. Now moving forward with the types of hypertension. Now first type is the primary hypertension. This type of hypertension is also called as the essential hypertension, and basically there is no identifiable cause that why this hypertension is occurring. So this type of hypertension is called as the primary hypertension, and almost 90 to 95% of population that suffer from hypertension is the primary hypertension only. Now the second type is the secondary hypertension. Now this particular hypertension, the identifiable cause, we know why the hypertension is occurring. Okay, now the 5 to 10% population suffer from this type of hypertension only. Then we have the resistant hypertension. Now in this, the blood pressure remain uncontrolled even after giving the two or more than two medications. Okay, so that type of hypertension is basically the resistant hypertension. Now the last one is the isolated systolic hypertension. This is a special condition where only the systolic pressure get increased, okay, and the diastolic remains constant. Now this type of hypertension is basically seen in the elderly patients. Mm, and the L-type calcium channel blockers are the best medications for this type of hypertension. Now, next we have antihypertensives. Now, what are antihypertensives? Now, antihypertensive agents are the agents or the classes of drug that can be used to control this hypertensive condition. Okay, so they basically lower down the elevated blood pressure. Now, along with decreasing the blood pressure, they can also be used to prevent the complications such as the stroke, okay, the increased oxygen level in the brain, and due to that, the brain get damaged. Okay, now that condition is the stroke. Then the heart failure, kidney damage, myocardial infarctions. For all that, we can use the antihypertensive drugs. Now, these antihypertensive drugs, on the basis of the mechanism of action, they are divided into different classes. So, the various mechanism these antihypertensive agents shows are the decreasing of the blood volume. That is the first mechanism. Basically, diuretics show that. Then reducing of the cardiac output. As I already told you that the cardiac output is directly proportional to the blood pressure. So if we decrease the cardiac output, then directly it will decrease the blood pressure too. Then the vasodilation or the modulation of the renin angiotensin aldosterone system, or the RAS system we can say, and to lower the systemic arterial blood pressure. So all these are the mechanisms. In detail we will study that further. Then next we have the classification of the antihypertensive drugs. So the first class under the antihypertensive drug is the diuretics. So basically diuretics, they decrease the that blood volume that results in the decreasing of the blood pressure. Okay, so first here is the thiazides. They basically act on the distal convoluted tubule. So there they act on the sodium chloride symport. Hence they do not allow the sodium and the chloride to reabsorb, and hence decrease the blood volume and result in decreasing the BP. Then second time is the high ceiling diuretics. They are basically the loop diuretics. They come. Okay, so they basically act on the sodium potassium 2 chloride co-transporter. So they act by transporter. So they act by blocking this particular co-transporter, and this co-transporter is basically located at the loop of ascending thick loop of Henle. Okay, so it is located there. The furosemide is the drug that is under this loop diuretic, and this is the most potent type of diuretic that we have in class. Then the last one we have the potassium sparing ones. They are present at the collecting duct, like the spironolactone is the example here. Then the next class we have the renin angiotensin aldosterone system, or the last RAS system inhibitors. The RAS system inhibitors. So basically, what is this RAS system? This RAS system results in the increasing of the blood pressure by vasoconstriction. So this is responsible for vasoconstriction that results in the increased blood pressure. So by inhibiting this RAS system, we can control our BP. So there is an enzyme called renin. that is released by our kidney. Okay, so this is secreted by our kidney. So basically, the enzyme that is the angiotensinogen. Okay, so this particular enzyme that is released from liver, so this renin helps in activating this angiotensinogen. Tensinogen. So basically, this angiotensinogen in the presence of renin, it is converted to the angiotensin 1. Okay, now this angiotensin 1 in the presence of the angiotensin converting enzyme is converted to the angiotensin 2, and this angiotensin 2 is only responsible for the vasoconstriction that results in the increase of the BP. So to control this condition, we inhibit this RAS system at different points. We use the medication so that we can inhibit this particular RAS system. Okay, so first are the ACE inhibitors, that is the angiotensin converting enzymes. So they do not allow angiotensin 1 to get converted to angiotensin 2. So this here is blocked, so hence indirectly they will block the vasoconstriction. Okay, so captopril, all the drugs that have pril as their suffix comes under these ACE inhibitors, like the captopril, enalapril, lisinopril, okay, ramipril, all these pril drugs are the ACE inhibitors. Now the second type of drugs we have is the angiotensin receptor blockers. So basically the angiotensin receptor is blocked due to these. So as the receptor is blocked, then angiotensin, where it will bind and show it action. So hence the RAS system is blocked due to that, and basically the drug that have sartan and their suffix comes under this class, like the losartan, candesartan, valsartan, all these, telmisartan, all these sartan drugs are the angiotensin receptor blockers. Now the next we have the direct renin inhibitor. So the renin that is released from the kidney, that is starting all this process. So directly that is inhibited by these direct renin inhibitors, and 𝘿𝙄𝑎𝑟𝑖N is the first drug under this class. Okay, now the next class we have is the calcium channel blockers. Okay, so I already told you while studying the isolated systolic hypertension that this is the drug of choice. The L type calcium channel blockers are the drug of choice for that. Basically in elderly patient that condition is seen, so the L type calcium channel blockers are the very good medications for that. Then under the calcium channel blockers, the phenylethylamine, under that the verapamil, that is the drug. Then next we have the benzothiazepine, the diltiazem is the drug there. Then dihydropyridines, okay, they have a nucleus of a dihydropyridine, like the dipin drug, that the nefidipine, amlodipine, felodipine, all these dipin drugs come under the dihydropyridines. Then the next class we have the vasodilators. So they basically act by dilating the blood vessels, that results in decreasing of the blood pressure. So the arteriolar dilator, so basically dilates the arteries, like the minoxidil or the hydralazine. Then the next we have the a non-selective one, that is that dilates the arteries, and the venodilators, the venous too, that are the nitroprusside sodium. Now the last class that comes under the hypertension, the antihypertensive drug, is the sympathetic inhibitors or the sympatholytic drugs. So basically the alpha blockers and the beta blockers come here, the non-selective ones, the selective ones. The beta blockers, like all the LOL drugs, the propranolol, metoprolol, atenolol, esmolol, all these are the beta blocker. Then the alpha blockers, the selective alpha blockers, like the prazosin, terazosin, doxazosin, all these. Then the alpha beta adrenergic blockers. Then the central sympatholytics, like the clonidine, methyl dopa. So all these are the drugs that are useful under the hypertensive condition, that are used to control the hypertensive condition. Now the next on, we are moving to the SARD, structure activity relationship of the ACE inhibitors. So this here is the journal structure for the ACE inhibitors, which consist of the phenyl ring here that is attached with the carbon chain, the long carbon chain. The n number of carbons can be there. Then we have a zinc binding group. Okay, then along with that zinc binding group, the N ring is attached. Now starting with this N ring. Okay, so this N ring is it must contain the carboxylic acid in its group. Okay, so why we need carboxylic acid in this N ring? So having carboxylic acid in this N ring, it mimics the structure or the C-terminal carboxylate of the ACE substrate. Okay, so it mimics that ACE substrate, so that's why we need the carboxylic acid in the N ring. Okay, now next, this N ring is the hydrophobic side chain, and this N ring is responsible for the increasing or enhancement of the potency due to its hydrophobic nature. So the substituent that we add to this N ring, it should be lipophilic in nature, so that will be optimum for the activity. Then if we take an example of the enalapril, that is the ACE inhibitor, the example of the ACE inhibitor, it has a phenyl ring in the place of the N ring, like here. Okay, so in the place of N ring we have the phenyl ring, and this phenyl ring is hydrophobic in nature. Now next we can take the example of lisinopril also. Lisinopril also has a phenyl ring in this N, in the place of this N ring. So this N ring is hydrophobic in nature, so it is important. Now the next we can talk about is the zinc binding group. Now what is the zinc binding group? This is also very essential for the activity, as this zinc binding group is present at the active site of the ACE substrate, okay, or the ACE enzyme. So due to that, it is very important. Now having this can help in better ACE inhibitor, to form the better ACE inhibitor or better activity of the ACE inhibitor. And the common zinc groups that we used, the binding groups that we use in our drug is thiol group, that is the SH, then the carboxyl group also, then the phosphinic group. Now these three are the main type of zinc binding group that are present in the ACE inhibitors. So here we have the example. Now here we see the captopril. So captopril has SH, that is the thiol group, as the zinc binding group. Then the lisinopril, it has the carboxyl group as its zinc binding group. Then enalapril, if we see, it also has a carboxylic group as a zinc binding group. Okay, then phosphinopril has a phosphine, the phosphine group as its zinc binding group. Okay, so this was the zinc binding group. Then the next is the presence of the proline. Now if our structure, or if our ACE inhibitor drug has the proline or the proline like ring in its structure, so it can be very helpful, or it can improve the binding of the drug. Now why? As it mimics the terminal amino acid of the angiotensin 1, having this proline, as proline is the terminal amino acid of the angiotensin 1, so it basically help in mimicking that particular drug, okay, that particular receptor. So this is very important. It helps in binding, better binding of the structure. So here we can see in the example, the captopril, it has a proline. Then the lisinopril, it too has a proline. Then uh, here also in enalapril also we have a proline group attached. In the phosphopril group also we have the proline group as a side chain, as the terminal amino acid, or the proline like chain. So this helps in increasing the binding of the structure or the improving the binding of the drug. Okay, so next on we are moving to the SAR of the dihydropyridines. So these are basically the calcium channel blockers. Now here we have a dihydropyridine nucleus. Now this 1,4-dihydropyridine nucleus is very essential for the activity, and if we make any changes to this N group, or if we add any substitutions, or we go on to the oxidation of this N, then it results in decreasing the or abolishing the activity of the drug. Now at this R1 and R2 position, CH3 shows the optimum results. Okay, so having CH3 there, it shows the good result. Then taking to the R4 position, so having the phenyl group attached, to this R4 position shows the optimum activity. But if we add at any substitution at the para position, or if we keep this phenyl the unsubstituted, so that results in decreasing or reducing the activity of the compound or the activity of the drug. Now next we talk about this R3 and R5 position. Having ester at this position is very helpful for the optimum activity, and if we place any electron withdrawing substitution here, that can result in the agonistic activity. Okay, so having the electron withdrawing group here results in the agonistic activity of the drug. Now next, this R5 and R3, if they are non-identical, means these are the different ester groups that are attached here. So this results in the chirality of this fourth carbon here, and it also results in increasing or enhancing the selectivity of the drug. Okay, so having these non-identical can be helpful. Now this was all about the SAR of dihydropyridines. So here the 2 SAR was important, so I have already discussed. Now moving forward to the drugs, one by one we will discuss here. Okay, so first is the captopril. Now it has pril in its suffix. So I've already discussed that the suffix pril comes under the ACE inhibitor or the angiotensin converting enzyme inhibitors. Okay, that inhibits the RAS system. Then if we talk about its structure, that we already discussed in the SAR portion, so having the proline like ring or the proline link can increase the binding activity. So here we have a proline ring. Then SH is there in the captopril as the zinc binding group. Okay, so this is also very important. Then we have a normal carbon chain. Okay, so this captopril has a very simple structure. Then if we move on to the uses, so basically it is used in hypertension, then congestive heart failure, post myocardial infarction, it also can be used in, then the diabetic neuropathy. So what is this diabetic neuropathy? Basically there is the neuronal damage, and that damage is due to the high glucose level on the blood, so that is called as the diabetic neuropathy. Then the second thing we have the side effects, the dry cough. Now remember, this dry cough is a very common side effect that we get with the ACE inhibitors. Almost all ACE inhibitors will show this particular side effect, and this is basically due to the increased level of the bradykinin. Okay, now next we have the hypotension. Sometimes we can face the hypotensive conditions too. Hyperkalemia, increase in the level of the potassium. Then the taste disturbance, that can also be seen with the captopril. Then the next we have the lisinopril. This is the another type of drug under the ACE inhibitors. If we talk about the structure, again we have a proline group in its structure. Then in the place of N ring, already discussed that, we have a phenyl here. Okay, then the zinc binding group we have here is the carboxyl group in the lisinopril. Now uses we have, again it can be used in hypertension, then congestive heart failure, acute myocardial infarction and the diabetic neuropathy. Then the side effects, dry cough, that is the most common one, hypotension, hyperkalemia again, dizziness and headache, as wherever there is the dilation, as it undergoes the vasodilation, the lisinopril, it causes vasodilation. So wherever there is dilation in the blood vessels, it causes dizziness and headache. Okay, now the next drug we have the enalapril. This drug also have pril as the suffix, so it also belongs to the class the ACE inhibitors. Now talking about the structure, here also we have a proline ring. Okay, the proline structure we have. Then here also the phenyl ring acts as the end ring. Then the carboxylic acid is the carboxyl group is acting here as the zinc binding group in the enalapril too, like the lisinopril. Uses the hypertension, the congestive heart failure, diabetic neuropathy, post myocardial infarction for all that. Then side effects again, the dry cough, the hypotension, hyperkalemia, dizziness, fatigue, all that are the side effects for the enalapril. Next drug we have losartan. Now we have a sartan drug. So angiotensin receptor blocker, ARB drugs. The sartan drugs are the ARB drugs. Already told you about that when we were discussing about the SAR of the when we were discussing the classification there, I told you about that. Then uses hypertension, then the heart failure, diabetic neuropathy, chronic kidney disease, for all that we can use that. Side effects, dizziness, hyperkalemia, fatigue, then angioedema. Now this angioedema is the severe condition. Now this can sometimes be life threatening too, and this side effect is very common with the sartan drugs. And this angioedema, this basically results in the severe swelling in the lip area, the tongue, okay, so all that, the throat, okay, so that can be life threatening sometimes, and it is very common with the sartan, the angioedema. Then the candesartan is the next drug. Uses again the hypertension, heart failure, left ventricular dysfunction, all that. Then the side effects, the dizziness, hypotension, hyperkalemia, fatigue, then angioedema, that is the most common one. The next drug we have here is the 𝘿𝙂𝘋𝑗𝑟𝑖𝑛. Now this is the direct renin inhibitor, the enzyme that is responsible for converting or activating the angiotensinogen to angiotensin. Okay, so that is the direct renin inhibitor or the 𝘿𝙂𝘋𝑗𝑟𝑖𝑛. The uses, if we talk about essential hypertension, where we do not have any uh, cause that why the hypertension has occurred. Okay, so the most common one, hypertension, the primary hypertension, it can be used for the treatment of that. Then the combination, now this 𝘿𝙂𝘋𝑗𝑟𝑖𝑛 can also be used in the combination with the diuretics or the calcium channel blockers. Okay, now the next we have the side effects. Now diarrhea is the most common side effect that we face with the 𝘿𝙂𝘋𝑗𝑟𝑖𝑛, as it blocks the reabsorption, sorry, uh, the reabsorption of the sodium and the water, so that results in the increased level of water there, so the diarrhea can cause. Then the hyperkalemia we have, then hypotension, rash, headache, all that comes under the 𝘿𝙂𝘋𝑗𝑟𝑖𝑛. Now next drug or the next class we have the diuretics, indapamide. Okay, this is the type of a thiazide diuretic. So thiazides, they basically act on the distal convoluted tubule, and they act by blocking the sodium chloride symport. So the sodium and chloride, along with some other electrolytes too, they are not reabsorbed by our blood, okay, or by our body. So from the name, like if we discuss the structure, so it has in their structure, or we can say ind at the starting. So from end we can remember that this structure has a indole ring in its structure along with the amide. So indapamide, amide here, so indole plus an amide group. Then as all the diuretics that you remember that have, mostly all of them, they have a sulfonamide group in their structure. So in this also we have a sulfonamide group attached along with the chlorophenol. Okay, the chlorobenzene, it has a sulfonamide group attached. So this is the structure of the indapamide or the type of thiazide. Then uses, if we talk about, it is used in essential hypertension, edema associated with the congestive heart failure and the nephrotic syndrome. Okay, for all that we can use the indapamide. Then the side effects, hypokalemia. Okay, that can cause hypokalemia, hyponatremia, decreased in the level of the sodium. Then hyperuricemia, the uric acid can be increased. Due to that there can be condition of a gout. Okay, so they can cause gout as they are increasing the uric level. Okay, then the hyperglycemia, dizziness and headache. Okay, so now this hypokalemia and this hyperglycemia, these side effects are linked to each other as the potassium level. Now whenever there is increase in the potassium level or the potassium channel open, it results in the increase of the insulin release. So this results in the insulin release. Now, as there is a condition of hypokalemia, that is the potassium is decreased, so the insulin secretion will also be decreased. So that will result in the increased blood sugar. Okay, so that causes the hyperglycemia. Hope that's clear. Now, next drug we have the furosemide. Now, this is also a diuretic under the loop diuretic that act on the sodium potassium 2 chloride co-transporter in the ascending loop of Henle, the thick ascending loop of Henle. It works there. So the structure, if we talk about, it has a furo in its structure. So from furo we can remember it has a furan ring. Okay, so along with the furan ring it has a carboxyl group, and as I already discussed, the diuretics, they have a sulfonamide group in its structure. So here we also have a sulfonamide group that is attached to the chlorobenzene again. Now, next we have the uses: hypertension, acute pulmonary edema, then hypertension, hypertension already discussed that. Then hyperkalemia, the increased calcium level, it can be helpful. Okay. Now the side effects, this also called cause the hypokalemia condition. Then hyponatremia. Okay, as this co-transporter is blocked, so it will result in decrease in the reabsorption of sodium, so hyponatremia. Then decrease in the level of the potassium, that's why hypokalemia. Then dehydration, hypotension, dizziness, weakness, all that can be caused by this furosemide. Okay, so basically these diuretics, they results in decreasing the blood volume. So due to that decreased blood volume, the dizziness and headache, they are very common symptoms that we can face, the side effects. Okay, now the next drug is the verapamil. Now verapamil is the calcium channel blocker, the non-dihydropyridine calcium channel blocker that comes under the class phenylalkylamine. So it, in the structure also we have a phenylalkylamine group. This side also the phenylalkylamine group. Okay, so the structure of the verapamil. Then the uses: hypertension, angina pectoris. Okay, whenever the chest pain occurs due to the decreased blood level. Okay, the blood oxygen, that is that is the angina pectoris. Then arrhythmia also it can be used. Then atrial fibrillation we can use the verapamil. Side effects now: bradycardia, hypotension, constipation, dizziness, fatigue, and one more side effect that is not mentioned here, I forget to mention, that is the peripheral edema. Now, this peripheral edema is the very common side effects that we face with the calcium channel blockers. Okay, so peripheral edema can also be caused as a side effect here. Then, next drug we have here is the 𝘿𝙄𝙎𝘾. Okay, now 𝘿𝙄𝙎𝘾 is the another type of calcium channel blocker, that is the benzothiazepine. Okay, now if we talk about the uses of this 𝘿𝙄𝙎𝘾, now benzothiazepine, as it is the benzothiazepine class, so it contain a benzothiazepine ring or core in its structure. Okay, then uses hypertension, angina pectoris, atrial fibrillation, flutter, supraventricular tachycardia. For all that we can use diltiazem. Then side effects: bradycardia, then hypotension, dizziness and fatigue. Okay, then peripheral edema. I already discussed this. Calcium channel blockers show this type of side effect very common. It's very common with the L type calcium channel blockers. Then constipation, headaches, flushing. Okay, all that can be the side effect of diltiazem. Then next drug we have the nifedipine. Now nifedipine is also a calcium channel blocker under the dihydropyridine. So basically these calcium channel blockers, they the calcium causes the constriction. Okay, so these calcium channels are blocked now, so they will cause the dilation of the vessels, so hence the blood flow or the pp can be decreased. Now nifedipine, if we talk about, it has the dihydropyridine ring or the nucleus. They are already discussed that in the SAR of dihydropyridine 2. Okay, so there we discussed that at this 1 and 2 here positions, the CH3 is the best thing, or the optimum, for the optimum activity CH3 is nice here. Then here we have the ester groups. Okay, now in this we have the identical esters. Okay, now here at fourth position we discussed that the having a phenyl group is good. Okay, so here we have a phenyl group. At ortho position we have a NO2 attached here. So this is the structure of nifedipine. Now uses, if we talk about hypertension, angina pectoris, vasospastic angina, then hypertensive emergencies, we can use Raynaud's phenomena. Now, what is this Raynaud's phenomena? This is basically the constriction of the blood vessels at the fingertips or the toes, and this is increased or enhanced by the stress and the cold, and this results in the bluish fingers and the toes. Okay, so this condition is the Raynaud's phenomena, and this basically happens due to the loss of oxygen in the fingers and toes due to the vasoconstriction. So the nifedipine, they cause vasodilation, so it is helpful in this Raynaud's phenomena. Then side effects: headache, flushing, dizziness, peripheral edema, palpitations, hypotension, all that is the side effect. Then we have nitrindipine. This is the another type of dihydropyridine drug or the dipine drug. Again, the structure we have the dihydropyridine nucleus. CH3 we have here. Now here we have different, the non-identical ester groups here. Then if we talk about this phenyl ring, again we have a phenyl at this fourth position, and here in the nifedipine we had at ortho position we had this NO2, but here in the nitrindipine at meta position we have NO2, and the rest of the structure is almost same, just the ester group is different. Here we have a non-identical ester groups, and here in the meta position we have the NO2. Otherwise the structure is almost similar to nifedipine only. Now next we have the uses: the essential hypertension, angina pectoris, then hypertensive crisis. All this we can use the nitrindipine. Then side effects: headaches, flushing, dizziness, peripheral edema, reflex tachycardia, all that can happen with nitrindipine. Okay, now next drug we have the minoxidil. So you must have heard about this drug too much. It is not basically used nowadays. It is mostly used for alopecia. Okay, for the hair loss condition it is very widely used worldwide or globally. Okay, So it is a vasodilator. It basically results in the dilation of the vessels. Okay, so that can also result in decreasing the BP. Now, uses, we have the severe or the refractory hypertension, we can use that. Then alopecia, the hair loss, we can use this minoxidil. Then side effects, the reflex tachycardia, fluid retention, headache, dizziness. Okay, so as this minoxidil is causing the dilation of the blood vessels, so the headaches and the dizziness, that is a very common side effects we get with vasodilators. You just remember that wherever there is vasodilation happening, we can have side effects of headache and the dizziness. Okay, then next drug we have the propranolol. Now propranolol, it belongs to the sympatholytic drugs, that is the beta blocker. So it is the non-selective beta blocker we have here. Okay, it acts on both the beta 1 and beta 2. Now due to its acting on the beta 2 receptor also, as beta 2 receptor are present on the lungs, it causes the bronchoconstriction there. So this propranolol, it can't be used for the asthmatic patients. Okay, it can't be used for the asthmatic patients. Then the structure, if we talk about, as from prop, we can remember that it has a propanol chain in its structure. From NO, we can remember that it also has a naphthalene ring. Okay, we also discussed this in my lecture in ANS. There also in under beta blocker, I have discussed this propranolol. Okay, so it has a naphthalene ring as a side chain. Then amine. Okay, it also has a amine group here. So this is the structure of the propranolol. Now uses: hypertension, angina pectoris, cardiac arrhythmia, post myocardial infarction, migraine prophylaxis, anxiety. For all that we can use propranolol. Now side effects: bradycardia, fatigue, hypotension, cold hand and feet. Okay, then sleep disturbance, all these comes under the propranolol. Now next drug we have the clonidine. Now clonidine is the centrally acting alpha adrenergic agonist. Okay, so it basically acts on the alpha 2 receptors. Okay, now this clonidine, it has the structure, that is it has a phenyl ring that has two chlorine. So from ClO-Cl, we can remember that it has a two chlorine groups or true chlorine groups in its structure, and these chlorine group, where they are attached to the phenyl ring. Then from 18, you can remember that it also has an imidazole ring in its structure. So we have a imidazole ring too, that is attached to the dichlorobenzene group with the amine bridge. Okay, then uses, if we talk about hypertension, withdrawal syndrome of anything, anything like the alcohol, the drug withdrawal, or the any type of medication withdrawal. For all that we can use it. Then the pain management, the clonidine is helpful there also. The side effects, if we talk about, is it causes the sedation, drowsiness, dry mouth, bradycardia, hypotension, dizziness, constipation. All that can be due to the clonidine. So these are the only drugs that we are going to discuss here. So these are not all the drugs under the class of hypertension, but most of the drugs that I found important from all the class, I took that and I discussed here. So hope this video will be helpful for you, and hope you understood the lecture and you enjoyed the lecture. Yeah, so thank you so much for watching the lecture. Thank you so much.